Good morning, everyone. Welcome to TY Hub Let's Talk podcast. We're live today with First Aid Coaching, and we're joined by PJ Carroll to talk about asthma and asthma awareness on today, the World Asthma Day. So thanks very much for joining us, PJ.
You're welcome, Fiona. So are we all set to go? We can kick off with
We're all live now. Good to go.
Very good. All the right buttons pressed.
Okay. All of them pressed.
Okay, well, welcome everybody. I'm going to do the presentations on behalf of TY Hub and First Aid Coaching. PJ Carroll is my name. And Fiona will be in the driving seat, so to speak, and helping us along here with all the presentation. So we'll move on to the first slide, which is going to give us some epidemiology of asthma. Now, what I got all my information from, just for your own information, is Asthma Ireland. It's a fabulous website. Got tons of information on respiratory problems, not just on asthma. They'll talk a bit about allergies, and they'll talk as well on COPD. And so the information I'm giving you here has mainly come from that website. They've also got tons of video, very, very good informative videos. So I would definitely recommend, if you've got anybody in your family with respiratory problems, that they go to that website, and there's an abundance of information. I've learned a lot myself just by going over their website in the last few days. My background would be ambulance service, so I would have dealt with a lot of respiratory problems over the years. When we look at this slide here, it shows you that it is a problem. I mean, 340 million individuals worldwide with asthma. That's a lot of people. And Ireland, for a small country, if you look at it, there's a prevalence of 7% in Irish adults and 21% in Irish children, which amounts to about 460,000 people in Ireland. That's a lot of people for a small country. So as you can see, maybe it's our climate or something. We go through and we look at some of the causes of it, but that's a large number. And worryingly so insofar as a lot of children, 21% of children with it. Right, so we'll have a look at the next slide anyway. These are the scary bits. And there's a poster there that Asthma Ireland put out, but I just took some of the pointers off it. And I had to start with the most worrying one. Is one person dies every 6 days as a result of that. Believe it or not, we could actually, we could bring that number down if we can just encourage people for the preventive measures. An awful lot of people, one of the problems we have is they're not taking their preventive medication when they should be. Once they feel fine, they just sometimes forget to take it. So it's so important that people manage their asthma and take their preventive medicine every day or whenever it's their prescription requires them to do so, even if they feel well. I think there is a problem. If you're having a good day, you might just forget to take your preventive medicine. If we can educate people a bit more and encourage that, maybe we can bring those numbers down. 4 minutes, that's how often someone in Ireland visits an emergency department with asthma. Ireland has the second highest, think about that for a moment, guys, has the second highest rate of asthma hospital discharges in Western Europe. So yeah, we need to open our eyes here. Over 40,000, the number of children registered under the asthma cycle of care program, they're just the ones who are registered, remember. 8,000, the number of asthma admissions to hospital every year. I know people always complain about the HSE and the services and so on. But you can see there's 8,000 asthma admissions where, again, if we could bring that number down, that will reduce some of the strain on the HSE. 5, the average number of school days missed every year due to asthma. So again, for all of you guys on board here who've got children with asthma, I'm sure you're very aware of how that can interfere with their learning and so on. 7, the average number of work days missed every year to asthma. So again, that's another drain on the economy and from an employer's point of view, but also from the point of view of people who are out sick with it. It's not what they want to be. They don't want to be out of work because of asthma. So it's a drain on them, and it's a strain on their families as well. And then the last thing, I put it in deliberately last because, it's only money, 472 million, the amount of asthma costs state per year. I never worry about the money end of it. If it's your health, it's your wealth, and whatever it costs to help people, it's irrelevant as far as I'm concerned. I'm more interested in the first few there, especially the one at the top. That's the most worrying one. We're losing one person a week from asthma. So let's see if we can do anything to reduce that number. Let's have a look at the next slide. I only found this out, wasn't aware that this happens. So this is very informative and very helpful. The Asthma Society of Ireland runs a number of asthma in the pharmacy days throughout the country. An asthma nurse specialists, they're available at these events to provide advice, support, and information on asthma. And they will be happy to help you to understand and manage your asthma. So that's a really, really helpful program that they have, which means that it's sort of a pop-in option for you. And if you have any questions about your asthma, or am I using my inhalers correctly, or the different types of equipment that people use when they're administering a medication, you can get all your answers there, because you're talking to the nurse specialists. These are the people who deal with this on a regular basis. I've always used the mantra that if you want to know about cold, talk to the coal miner. So to be able to talk to a nurse specialist on this condition is definitely beneficial to you. And, you know, even though you might not catch them in the pharmacy, we do have, as I said, a very good website, and you can always ring somebody as well. So the services are there, and they're pretty good, in fairness. Okay, let's see what's popping up next. So what causes asthma? It can start at any time in life, although it most often begins in childhood. Sometimes it runs in families, along with other atopic conditions in the family. Some children's asthma is related to other conditions, such as eczema, hay fever, and allergies. Adult onset asthma may develop after a respiratory tract infection. You will also get with asthma, occupational asthma. So people later in life, maybe the job they're in was very dusty. Chicken farmers, poultry farmers, for example. People working in the mining industry. Bakers, where they're surrounded by flour and all those fine little powders and such. Even guys working in where they refill extinguishers, especially the powder extinguishers, have to wear all the PPE, the protective equipment, when doing so. There's a thought process there that many aspects of modern lifestyle, such as changes in housing, diet, and more sterile home environments, may have contributed to the rise in asthma over the last few decades. I remember somebody saying to me a long time ago that nowadays we're a bit too clean in our houses, and that all the chemicals we're using to clean our houses could be killing off a natural defense against asthma. Now, I don't have anything in writing to prove that, but you know, there may be some truth in it. Another point it was made to me was that children, and maybe different generations, certainly, children nowadays probably spend less time outdoors. That a lot of time is spent indoors on, PCs and what do you call them, PlayStations and so on. I'm very old, and in my day, you know, you got a kick in the backside and go out to play. You went out in daylight, you knew to come home when it got dark, or you got hungry. There was no internet, there was no phones, and that's how we rolled, so to speak. So I don't remember hearing an awful lot about asthma when I was growing up. There certainly were people with it, but it certainly seems to have increased over time. And during my time in the ambulance service, I would have seen a lot of respiratory problems, more and more every year. What actually helped a lot back in the day, in the 90s, was when they brought in the smokeless fuel in Dublin. Because over the weekends, in particular, if you're working the ambulance, especially over the weekends, you seem to get an awful lot of people coming in with respiratory problems. And then when they brought in the smokeless fuel and coal and so on, those numbers dropped. And I mean, it was a noticeable drop. And then the next best thing that they introduced was the no smoking. You know, no smoking in the pubs and the restaurants. And that in itself has reduced a lot of respiratory problems. What was always interesting to me was the amount of asthmatics who smoke was absolutely ridiculous. You know, and of course, smoking is not going to help anybody. And it's not going to help anybody, in particular those who've got asthma. All right, we'll have a look at the next slide. So some of the triggers, and it can be a combination, not just one trigger, but as you can see, quite a lot of them there. Straight away, I'm looking at smoking. But smoking is there. Dust, fungus, cold air, so the weather can play a part. Stress-related asthma attacks. People can be allergic to animals. Exercise, I'm going to use that one as my excuse for not doing exercise. You know, it might bring on asthma. Certain times of the year, pollen count is up. My own son suffers very bad with hay fever. Bugs in the home, pollution, chemicals, quite a bit, guys. You know, there's not just one singular thing. But you may have people who are more sensitive to a number of triggers, and therefore it's back to the management. And the trick is always how they manage their asthma, and in particular, the preventative measures, the preventative medication that they should be taking. Okay, so we move on then to the next slide. So we're going to have a video here, and this is just giving you some insight about what you can do in not just this, in this case, it's a child's bedroom or a teenager's bedroom, but You can do it to any bedroom for anybody in your family who might have asthma, and it's about reducing dust really and other triggers. So we'll roll it there collectively, say.
If your child has asthma, try to eliminate as many risks as possible in the room where they sleep. After all, 1/3 of the day is spent in bed. This room has been decluttered. Firstly, we have no curtains or carpets. The curtains have been replaced by washable blinds and we have wooden floors. Now these should be washed regularly. They can be vacuum cleaned easily, and it's recommended that you use a vacuum cleaner with a HEPA filter, which is more effective for capturing the dust mite. Now the bed itself has a leather headboard, and this can easily be kept dust-free with a damp cloth. The bed itself has no base and you can vacuum and wash the floor. Now for the bedding, the mattress, duvet and pillows, they all have protectors on them, and these act as a barrier against the dust mites getting into them. In terms of choice of duvets, feather duvets are suitable for some people but may act as triggers for others. It is recommended to wash all bedding at 60 degrees or over, and many people with asthma are more comfortable with synthetic duvets and pillows. The mattress protector must encase the mattress fully, not just like a fitted sheet. It should be tightly woven with firm zips and not fasteners, and they must be breathable. There are several brands available on the market, but not every mattress protector is effective. So please contact the Asthma Society of Ireland for advice on which brand to choose. Pictures. As you see in the room here, the pictures are behind glass so they can be easily cleaned with no posters or dust gathering clutter. CDs and DVDs, a feature of many bedrooms, should be stored in a wallet and not on a rack to gather dust. Remember to empty the bin regularly, never leave it too full, and many kids, including teenagers, still have a favourite cuddly toy. Be sure to wash them regularly at 60 degrees or over, and it might even be an idea to have two of the same.
Okay, so the most surprising thing I saw there was the tidiest teenager's room ever.
I was just thinking the same thing, PJ. It's basically less clutter, less dust, and it would help all rooms for anybody. It's not just really asthma; it's for anybody really as well, to keep your, anything that hides in the dust can bring on any respiratory.
Well, it could trigger an allergy, which can lead to a respiratory problem as well. What else you can do there as well, what's always recommended over the years, was you can hoover your mattress. I know I'm talking about mattress covers, but you can actually hoover your mattress, and turning it regularly would be a good idea. And plus also changing their pillows. I know we get pillow covers and protectors, but the actual pillow itself, changing that on a regular basis. And I'm not talking about every week. I mean, every maybe a year or 2 years, you could just invest, not that expensive, and put new pillows in completely. Mattresses are expensive, so mattress covers are a more economic way to deal with that. All right, so we have our next one. So this is a peak flow meter, and again, the video is coming from Asthma Ireland, showing you how to use a peak flow meter. So this is something that people can have at home, and it helps them, I suppose, monitor their respiratory condition, monitor their asthma for argument's sake, and keep an eye on what their levels should be. And you will have a starting point. I can't give you an actual figure of what would be, what the readings I'm looking for. Because you'll see here that you do an average of 3 tests, and you take the best one each time you test. And after a while, you then work out what your normal respiratory rate should be, or normal respiratory condition. So it's like a lung test, a breathing test for each individual. And it will give you a bit of a heads up if you keep a chart on it, so to speak. You'll notice the days that your breathing is not good, and you'll notice the days when your breathing is actually a little bit better. So we'll run the video and you'll see how this device is used.
Now I'm going to show you how to use your peak flow meter. Where a separate mouthpiece is required, attach the mouthpiece to the peak flow meter. Ensure that the cursor is back to 0 and that your fingers do not block the movement of the cursor. Hold the peak flow meter level or horizontal while you sit or stand as straight as possible. Take a steady deep breath in and hold the breath while putting the mouthpiece in your mouth between your teeth, and close the lips around the mouthpiece. Blow a hard, fast breath out through the mouthpiece, not through your nose. Measure where the cursor stops. Repeat the process twice. Record the highest of the 3 results as your peak flow reading onto your peak flow chart. Where a separate disposable mouthpiece is required, dispose of the disposable mouthpiece and make sure that your healthcare professional explains the results and action steps if required.
Okay, so that device, as I say, gives you a bit of feedback on what your pulmonary function is like. And obviously, with Asthma Society of Ireland there, what they're showing is the device that you can use if you have to share that device. There's a number of people use the same peak flow meter, then there's disposable mouthpieces. However, if it's your own one and you're not sharing it, you don't have to worry too much about those. And it is 3 attempts. It was slightly confusing when she said, twice, but do it 3 times and you take the best of the 3 readings. What we're looking at next here, guys, is asthma inhalers and devices. And as we go through this, you're going to see there's quite a lot. So what you have here is inhaled corticosteroids. I can't even say the bloody word, lads. They're steroids for short for me. Okay, bear with me, I'm old. All right. So inhaled steroids, quite a number. Now, these are your preventative measures. You can see they're to reduce inflammation, taken daily to prevent asthma attacks. The idea with controlling asthma is that you don't actually have the asthma attack. That's what you're trying to avoid. So whatever one you're on, and you can see there's quite an assortment, slightly different how they will be delivered and so on. Some will be a vapor, some will be a powder. And again, your pharmacist, your doctor, and the Asthma Society can certainly give you plenty of a heads up on this of what's best for you. Right, we'll have a look at the next slide. Here we have combination inhalers. So what they're telling you here is multiple medications in one inhaler. So what you actually have is a preventative measure and a treatment. So it's sort of clever in a way. And really what happens is, remember, with your consultation with your GP and with your pharmacist and everybody else involved, they'll work out what is the best plan of action regarding medication for you. So they might decide combination inhalers are best for you. And again, you have an assortment of ones that are vapor and ones that are powder based. Again, these are taken daily. So our next slide. Short-acting bronchodilators and long-acting bronchodilators. Now, bronchodilators are just fancy words for opening up your bronchial tubes. To dilate means to open. So in your broncho is short for your bronchial tubes here. Again, we have the short-acting ones, a rescue inhaler, they call them. It'll open your airway. It's quick relief for any sudden attacks, a sudden onset. Then you use your short-acting bronchodilator. And then you have a longer acting ones, which open the airways. These are taken daily again. And you can see here mentions to control COPD or asthma. So COPD is chronic obstructive pulmonary disease. We'll do more with that in a moment. A very common short-acting bronchodilator, you'll see it there on the top row, the second from the last there. Salbutamol are often referred to as Ventolin, okay, Ventolin inhalers. So they're one of the more common ones, but there are other types that you can see on the bottom row there. All right, the next slide. These are spacer devices, and you can see there's quite an assortment of them. But these are really clever devices to allow people to actually get the full, I suppose, measured dose of their inhaler. It's unlikely they're going to be carrying this on their person. Parents will certainly carry one for small children. We're going to show you one in particular in a moment. That's the baby inhaler. Let's just see that one. Again, the Asthma Society have loads of videos on these. One little tip with them, when you get them first, it's a good idea that they're washed out with soapy water and allowed to dry fully before you actually use them. And then every couple of weeks you should maintain it. So you keep them clean basically. But the reason why you want to wash them in advance is to prevent the medication from sticking to the inside of the spacer device, and then it's to maintain that plan going forward. We'll run the video here and you'll see how the baby inhaler works.
I'm going to show you how to use the baby inhaler device. This technique applies regardless of the medication delivered in the device. This device is for use in children under the age of 4. First, remove the mouthpiece cover from the meter dose inhaler. Shake the inhaler and insert it into the inhaler holder of the babyhaler. Place the face mask gently over the baby's mouth and nose, ensuring there is a good seal between the mask and the face. Hold the babyhaler and the inhaler at an angle that is comfortable for the adult and the baby. Press the inhaler canister once to release a dose of the drug. Keep the babyhaler face mask over the mouth and nose until the baby has inhaled at least 5 to 10 breaths. The blue valves will move slightly as the baby breathes in and out. And remove the face mask from the baby's face. If a second dose is required at this point, wait 30 to 60 seconds before repeating the process. Remove the inhaler from the babyhaler device and replace the cap. If using a controller inhaler, it's important to rinse the baby's mouth out after use with water.
So you'll notice at the end of that they mentioned about rinsing the baby's mouth after using an inhaler. That's a good I suppose, piece of advice. But also for anybody under preventive medicines, typically the steroids, once they've taken them and they've got the benefit of them, it's no harm to rinse their mouth out either. It can actually help prevent oral thrush, which can be a risk factor with the steroids when you're taking them, especially taking them every day. All right, let's have a look at the next slide. So this worried me slightly when I was looking, doing a bit of research on this, and it says 1 in 5 people with asthma would not know the 6 most common symptoms of an asthma attack. So education, guys. So it's good to inform people. So this short video is going to bring you through the most common symptoms of somebody having an asthma attack. So from your perspective, if you're out and about, not just with family, but you might witness somebody else in the public domain. You could be in this little coffee shop here, and you see something like this develop, then, don't be afraid to sort of think, oh, this could be an asthma attack, and approach the person and maybe be able to render some first aid and assistance to help this individual here. Let's have a look at the video anyway, and I'll give you the 6 most common symptoms.
Couldn't stop coughing. It was exhausting.
There were people all around me, but I couldn't get the words out.
I was fighting for each breath. I felt like I was drowning.
The wheezing made me feel like I was breathing through a straw.
It felt like an elephant on my chest.
When I saw my little girl's lips turn blue, I knew it was an asthma attack.
It was scary.
Painful.
Frightening.
Traumatic.
Asthma kills 1 person every week in Ireland. Know the rules to save a life. Visit asthma.ie or call our advice line on 1800 44 54 64.
So there you go. Getting to understand those symptoms. I wouldn't be surprised if people misinterpreted that as a heart attack, especially when someone's having a severe asthma attack. It actually looks quite similar. But once you start to, I suppose, assess the patient and work your way through their signs and symptoms, you'll start to realize what it is. Of course, if it's a known asthmatic, in fairness to them, a lot of them know what to do, but that doesn't stop people from having a bit of a panic attack as well. I think we could all be guilty of it. If we're struggling to breathe and we got tightness in our chest, and you're wheezing, and when you start having respiratory problems, you might get confused and disorientated. So all those things can be added to it. So it can be very, very frightening for the individual, and of course it can be frightening for people around too. The trick is trying to stay calm and approach these people, and if they have their medication, as we'll see as we go along, is to encourage them to take their medication, and then monitor them to make sure that their medication is doing what it says on the tin, so to speak. So family members, friends, colleagues, anybody has asthma, I wouldn't be holding back having a conversation with them and saying, are you fully aware of all the typical signs and symptoms? And just have that conversation, especially if it's family and friends. We're going to have a look at now the treatment, basically, of an asthma attack. For the next slide.
yeah, just before we move on to that video, PJ, if anybody has any questions at all, just pop them into the chat or the comments. Or if you're watching it with a school, ask your teacher to pop any questions there. The most important thing is that people to come away with the right information from this podcast on how to react and how to help out as well. And also, if you've got asthma and you've got questions that you didn't think you had before and you have now, and you don't really want to put them out there in front of everyone, it's okay. The comments are only seen by ourselves, so we will just mention it if you don't want to have your question aired, and we can have that answered for you and sent to you after the podcast. So I'm going to play the video now.
There's another, yeah, once you run on here, you'll see there's another chart.
Symptoms of an asthma attack can include one or any combination of the following: coughing, wheezing, shortness of breath, difficulty finishing sentences, chest tightness or lips turning blue. If you feel an asthma attack coming on or are with someone who does follow the 5-step rule, Step 1. Sit up and stay calm. Do not lie down. Step 2. Take slow, steady breaths. Step 3. Take 1 puff of a reliever inhaler every minute. This is usually the blue inhaler. Children under 6 years of age can take up to 6 puffs in 10 minutes. People over 6 years can take up to 10 puffs in 10 minutes. Step 4. If the symptoms do not improve after 10 minutes, or if you are worried at any stage, call 999 or 112. Step 5. If an ambulance has not arrived after 10 minutes, then repeat Step 3. Remember, if someone has an asthma attack, do not leave them on their own. Use a spacer if available, and make sure they see a healthcare professional afterwards. An asthma attack is an emergency, so act now.
What's worrying there, guys, was that the 69% of people with asthma did not know or do not know the 5-step rule to manage an asthma attack. So again, very important that people would understand those steps and what to do. There's often an assumption because somebody has asthma, well, they'll know exactly what to do, but the facts and stats are showing us that not always true here. But from our point of view, on the outside looking in, so to speak, when we're trying to assist people and treat people, is allow them to take their medication and to monitor them, because you're looking for recovery. You want to see breathing improve, you'd like to see their color improve, any discomfort they have would dissipate. Everything we want to be on the up. And it also pointed out that it's okay for people to take repetitive doses of their inhaler. Just to refresh your memory there, if they're children, they say they can take up to 6 puffs in 10 minutes, whereas adults can take 10 in 10 minutes. You have to ask yourself the question, though, if they're not responding well over that 10 minutes, you're going to need to call 999 or 112. And the emergency controllers, once you get onto them, the emergency call takers, they will certainly advise you and step you through and assist you. So you're never on your own, really, as long as you remember to ring 999 or 112. Okay, we'll have a look at the next slide. And this is just showing you again, if you're using your reliever inhaler more than twice a week, you are over-reliant on it and your asthma is not controlled. So that's typically your blue inhaler. The exception to this is people with asthma who participate in sports or exercise. It is still recommended you use your reliever inhaler prior to warming up before exercise. So the word there, asthma exacerbation, really means a flare-up. And what's interesting is that using 3+ reliever inhalers a year puts you at a higher risk of a flare-up. I know people who've got asthma and their inhaler is an ornament. They hardly ever use it, which is not bad news. That's good news. But then I know people who go to 3, maybe 4 of those inhalers a year. So it's telling you how bad their asthma is, or maybe the lack of control that they have on their asthma. We're going to have a look at the next slide. There's lots of different, what they call care plans or action plans out there for different conditions and such. But this one from Asthma Society of Ireland is particularly good. It's a really good care plan. So is the others. I'm just picking on this one in particular because a lot of information on it. It's available. You can download it for yourself, and we would strongly recommend you do it. And it's great for you just to record everything, but it also gives, should you need hospitalization, should you need to call the ambulance, should you need to go to your doctor, to have this care plan in place is very informative for them. Because remember, sometimes if somebody has to get medical assistance and they're struggling to breathe the more, they want to concentrate really on treating themselves and so on. Having this already set up and filled in and completed can be passed on to the emergency service when they get there, which is going to, again, speed up all the processes of people getting treated. So I'm not going to read every single piece of that out for you guys. I'm just highlighting that it's a really good care plan. That's the front of it. We move the slide on, you'll see the back of it. And the zone you want to be in is the green zone. You don't want to be in the red zone. I wouldn't even want to be in the orange zone. So my plan would be with asthma, if I was, I don't have asthma, thank God, but if I was an asthmatic, I would be gearing myself up to be in that green zone as much as possible and avoid the red zone as much as possible. And all the information is there, and it's very, very helpful. And it's going to not take that long for you to sit down when you're having a good day and fill it out and keep a record and keep a track of things and monitor your condition because, if you do need medical assistance, this will be invaluable. Okay, we're going to move on to the next slide. And what we have here is COPD. Chronic obstructive pulmonary disease is a disease that makes it hard to empty air out of your lungs. So basically to exhale. This is because the airways get smaller, leading to airflow obstruction. Now, I hope you can see on the little charts that are there, it's giving you some of the causes of COPD. So you got chronic bronchitis, asthma, and emphysema. What I can point out here is emphysema is the main cause of it is smoking. Now, you might also start to think that I'm anti-smoking. I don't care if you smoke, it's your own call. I'm not buying a cigarette, so I don't care. But, I'm sure you're all intelligent enough to know that they're a curse. They definitely are. They're very difficult, very addictive, very expensive. And, if you're trying to get them up, the best to look to you, but it does lead to emphysema. And what that simply means is that little air sacs in your lungs that trap oxygen. That's the whole idea. You take a big deep breath in comes the oxygen. Little air sacs are called alveoli. You see bottom left there, healthy alveoli. Layman's terms is air sacs. They grab the oxygen. And then your blood is on the way over to pick up the oxygen and bring it to your body. And your heart will pump it around your body. What happens with emphysema is those little air sacs become inflamed. And so therefore their ability to hang on to oxygen or hold oxygen is impaired. There's no cure for emphysema. And there's no age restriction on it. So in my time in the ambulance service, I've treated people in their 30s and 40s, for example, with emphysema. And remember, there's no cure for it, so they're going to spend the rest of their life on oxygen a lot of times, maybe up to 15 hours a day or 24 hours a day, or always having to carry a bottle of oxygen with them wherever they go. So no, not a pleasant condition to have. Say bronchitis is there as well, which is inflammation of the bronchial tubes, and asthma. When they use the word chronic, they're really talking about a condition over long periods of time. Whereas when they use the word acute in health, it's normally something that happens suddenly, and chronic is progressive. The pictures are showing you what a healthy airway should look like. And then you look at the bronchial tubes during bronchitis, how inflamed they are, and you can see how difficult it is for air to pass through. So I suppose we'll all would agree on this program here is that if we could avoid these conditions, and if we have any way of avoiding them, we have to seriously look at that. That's the best advice I can give you in this. You can see they've sort of mixed in a number of respiratory problems into the same pot here, and then your treatment can be very similar then as well.
I know you've mentioned smoking, but vaping is a big thing now as well. Does that come into the COPD at all category?
It will. I think it will because we're hearing of popcorn lung. So this is, and there's not vaping has been around quite a bit now, and I think what's happened is, unfortunately, when they start bringing out all these nice flavors, it's encouraging a certain age group to take these on board. In the early stages when vaping came out, I think a lot of people were looking at it from a positive point of view. They're saying it's going to help people give up cigarettes, because they're taking a lot of the carcinogenics out of cigarette smoke, and they were just dealing with, what were the main problem was nicotine. And that was the idea, maybe to wean people off cigarettes and hopefully get off vaping as well. But I think all the evidence has shown that didn't really happen. We seem to have an increase now in vaping, and in particular with children, young teenagers.
That's going to be new figures, I'd say, coming out soon enough about how that's
it's only a matter of time.
Yeah, I mean, like it causes other illnesses that we don't even know about yet, but they are all respiratory and long term. So if you have, you know, like if you get them when you're a teenager, they're never going to go away.
No,
Those,
but it's also going to lead to lots of other complications. You know,
yeah,
once you get respiratory problems, if you're dealing with respiratory problems, that's going to put pressure on your heart, you know, and other vital organs. So everything else, you know, it's like a domino effect. If you're
yeah,
damaging one system, like your respiratory system, then other systems of your body have to try and compensate. So what you'll find with COPD, when people are put on the nasal cannula for the oxygen, people are always thinking they're giving them the extra oxygen because of their breathing. That extra oxygen in this situation is actually to help their heart, because
right,
our heart is working overtime to try and get the small amount of oxygen that are in the lungs around the body. So the right side of your heart now works harder than it ever had to do in the past. The left side of your heart was always the workhorse because it's pumping blood around your body. The right side was only pumping to your lungs. So now suddenly it's in trouble. So we give the extra oxygen to help the heart muscle so it can keep doing what it's doing. So this can lead to lots and lots of complications, you know. Okay, so what we're looking at here are EpiPens, as we call them. Now, the correct term, in case it comes up in the pub quiz, is auto-injectors. So the question is, what is this and what's it for? Well, therefore, most of you probably will remember or know, and a severe allergic reaction. And when we normally refer to that as severe allergic reaction as anaphylactic shock. So what you have is the ones on the left, as we're looking at them there, there's a green one and a yellow one. That's your classic EpiPen. Now, EpiPen is just short for epinephrine. It's a laboratory manufactured adrenaline. And some clever person managed to put it in a plastic delivery device there. And then that's administered by, you know, basically typically injected into their thigh. The Jext, Emerade, and Anapen have the same medication, okay, and more or less the same delivery system. But obviously, the people who put epinephrine in a syringe the first time, they get to call it the EpiPen. But it's a bit like we all call our vacuum cleaners Hoover. It's just a brand sticks in your head, that's all. Well, why I'm mentioning them at all here, that when you, especially with the schools and that, the parents with children in a school will often bring in the child's medication, and you could be looking at it and you see there's different types. When I say different types, different brands, but they've all got the same medication. The only one where you actually press a button to deliver the medication is the Anapen. And if you're looking at it, where the word Anapen is an arrow, that points to a little black cap. When that cap is removed, there's a needle on that end. On the far end, there's a small little black cap on the top of it with a red button underneath it. So once you're ready to use it, it's placed against the person's thigh and they press the red button to discharge that medication. Whereas the rest, you just hold it firmly, press it firmly against the thigh, and it'll automatically administer the medication. So that's just a little bit on those devices. This in its own, on Anapens, EpiPens, and on anaphylactic shock, we could spend the whole day chatting about this one. And it's always a challenge for the schools and such when it comes to medication. Let's have a look at some of the next slide, some of the types of common allergens. So you can see quite a bit. People can be allergic to quite a number of things. I've come across people in my time who are allergic to allergies. You know, I'm allergic to Piriton. Now, Piriton is, you know, an antihistamine. So I had a reaction to an insect bite a number of years ago, and I took Piriton to reduce the symptoms, and my condition got worse. I only noticed after I took the second Piriton, it really got worse. So I was more allergic to the treatment than I was to the bite. Those who know me would say, not surprised, because I'm an oddball anyway. Right? But you can see there's airborne possibilities, skin, food, medication. I'm not going to read them all out to you guys. You can see when you look at the list, there's quite a lot of possibilities there. So therefore, there can be combinations. Now, when people have an allergic reaction, we should have a slide showing different, I suppose, signs and symptoms. I will come to in a moment. There's the one from the food. I'll go to the next slide there, Fiona. We look at the food, the Irish Food Allergy Network. Another great source of information for you. And it's particularly from, not just from the family point of view, but also from the school point of view. As you can see here, excuse me, food allergies are a growing food safety and public health concern across the Western world. And in Ireland, 4% of children now have food allergies. So again, schools can be very proactive, and I know they can be insofar that they have a child in a school with an allergy. It's putting measures in place, so if it's that, you know, letting other families know, other parents know. excuse me, that if they're sending their children in, to avoid bringing certain food products, such as peanuts, for example, because kids might not know any better and they would just share food or, share lunch or something with the kids. So you can.
With the nut allergies, is it right that it's not just some of the allergies are so bad that it's not even eating them, that it's just being around those things that they're allergic to that can cause?
Yeah, if you look at it, Fiona, if you look at the airlines, in my time when we, back in the day when you flew, you could bring anything you want with you on the aircraft. But whereas now you'll often get a message over the tannoys that we have a passenger on board who's got a nut allergy. So please do not, open any packets of nuts that you may have bought in duty free. So they stopped. Used to give out little packs of nuts. They stopped doing that. So they will flag it up on an aircraft to let all the passengers know that they may have a high risk person. Aircrafts recirculate the air. So if somebody down the back was to open a packet of peanuts, the person at the front could still be exposed to that allergen. So they could be hypersensitive to it. So you're right. You don't actually have to physically, eat the peanuts. It can just be around, within their area. And if you're to Google it, you'll see some stories of people who've actually caused problems on aircrafts by not listening to the advice from the cabin crew and still went ahead. I think it was 2 or 3 years ago, there was an incident such as a parent on an aircraft wanted to give their children peanuts and said to hell with the rest of them because a problem where the plane had to divert and they got in trouble over that. So, the problem with sometimes, lads, is that we're dealing with human beings and they're the most unpredictable species on the planet. So
it is a question why, when the school sends out a letter as well to home, and to everybody, or an email saying we can't have a student that's severely allergic to nuts. It's usually nuts. Please ensure that you don't have any nut products in your child's lunch. There is a reason for that, and I know it's annoying, but we want to keep them all safe, don't we?
Well, we don't want anyone to die. I mean, that can be the worst case scenario. We don't want anyone to die should they be exposed to this. Now, there are thousands of people having allergic reactions every year. And the number of people who will die from true anaphylactic shock in Ireland is probably 1 a year. Now, we're not lowering that down or trying to undermine that in any manner, shape, or form, because one is one too many. And when it's a member of your family, it's very, very real. That's for sure and certain. And I think everybody remembers an incident back in 2013 where we had an incident in Dublin where a teenager died on the streets from a nut allergy. And that, I suppose, kicked the door open a little bit. And, people still talk about that incident, even though it's 2013. There have been incidents since. But I think people got a bit more educated, and certainly organizations got a bit better organized in trying to educate themselves and such on it. Again, you can see here, which is also very helpful for the schools and parents, is that, the Irish Food Allergy Network have a care plan. And as I said to you before, I like to go straight to, the main man, so to speak. So I'm not going to create a care plan when one like this already exists. But it's not enough just to get it, guys. You have to fill it in. You have to put in the information. What I like about this one, especially for the schools, you can have a photograph of the child there. You can have all the information about the child's medical history. Because sometimes the child is in the school and you're given a care plan and you're given the medication. But what's important is to find out when was the last time the child had a reaction? And when they did, how did they react? And what were the interventions then by their GP? And was the child hospitalized? And get as much information as you can about that child's medical history regarding this. And then have everything else in place. So in other words, your plan, your consent to administer, that the parents have to come in and advise you. The parents should really show you how to use an auto-injector. It's a challenge for the schools to get around this problem, because to get certified to administer this is quite difficult. It's not an easy process. So what you should try and do is put as many steps in place yourselves. Good conversation, open conversation. I want consent from the parents, that if I have to assist your child with a medication or administer that medication, that you're telling me I can do so. And then I have an action plan that I can follow with all the information about that individual in front of me. I will have the medication provided by the parents. The parents are obliged to do so. Medication prescribed by the doctor through the parents to the school. So the school are not going to be able to go to the pharmacy and buy this stuff. So the parents have to provide it. Make sure it's the right medication for the right child, the right dosage, that it's in date. All these little things you want to make sure of. And then from the school's perspective, will be that they have some sort of a management plan that they can check and make sure that that medication is valid, it is in date. The EpiPen has got a clever system on it, because apart from the fact that it has the expiry date on the container, it also has a little window in it. So if you were to hold it up to the light, you should be able to see right through that little window. It should be crystal clear. And if it's cloudy, it's gone off. So it could be in date, but it could still go off if it's in like direct sunlight, for example. You got to keep it around, I think it's around less than 25 or 26 degrees. So as the weather picks up now here in Ireland, people might have these in a handbag. They might have them in the glove compartment of a car. They could be maybe in direct sunlight in school, wherever they're stored. I don't know. But it's to make sure that they're kept more or less at room temperature. And that should preserve the medication for as long as possible. Another thing that's come up with me, because I've done some training in schools over the years, is that when the medication is provided, it's brought in by the parents, and we dot the I's and we cross the T's, that medication then is removed at the end of term, that it's not actually left in the school. And so it comes in with the parents, or goes out with the parents. And then when kids come back to school, we start the ball rolling again, check everything again, and off we go a second time around. Did you want to add anything to that, Fiona? Are you happy enough with that?
No, that's excellent. I mean, like for everyone's safety, having first aid training, no matter what age you are, is excellent. And yeah, I mean, like, you do forget, women in particular do forget what's in a bag. Students, there's science experiments that go on in students' bags as well. I remember packed lunches might have been in there for about 6 months. But anyway, so you would forget. So I mean, like, knowing that there's a little way of checking the medication for that is definitely an eye opener.
Yeah, the packed lunch, 6 months is giving you a penicillin, which you never know, you might need it. All right, we'll have a look at the next slide, which is basically showing us how you might recognize signs and symptoms of an allergic reaction versus an anaphylactic reaction. So we have a mild reaction, is just rash. And if you do nothing, it often runs its course anyway. But an antihistamine might help there. The child in the middle looks worse for wear because of a lot of swelling around the mouth and the eyes and that. So again, moderate reaction would be considered rash and swelling. It can get really nasty for people, though. You'll see people, the nose is running, their eyes are streaming. They feel terrible. It can also lead to people with incontinence and vomiting. So it can get pretty nasty. So it's, we've got to be reactive to these things. As if it's just a rash, most people are not going to be too fussed by the rash. Whereas, as I said, the first guy possibly do nothing, it'll run its course. The person in the middle is going to need medical assistance, there's no doubt about that, to help them with their condition. But when we look at anaphylactic shock is where it interferes with your breathing and your circulation. So what we have here is somebody with difficulty breathing. Their bronchial tubes are constricting. So they're starting to constrict, which means it's difficult to pull air in. What we don't see, because we don't have X-ray vision, is that her blood vessels are starting to dilate. Now, with her blood vessels dilating, then what happens, you get a drop in blood pressure, which is detrimental. So when somebody has an allergic reaction, you should respond, because what you're weighing off is that it doesn't turn into becoming an anaphylactic reaction, if that makes sense. So always react to the allergy, and then your interventions may actually prevent the anaphylactic shock. So we should have the video coming up next. Yeah, here's a video on somebody treating somebody who's having an anaphylactic reaction to, I think it's peanuts or nuts in the food.
As I was saying, we're off to Spain for a fortnight.
All right.
This time next month, eh, darling?
That's lovely. I haven't been this way.
Oh, we've been a few times. Yeah.
All right, okay. Where are you flying?
We're flying from Manchester this time.
Okay.
Yeah, really looking forward to it.
So what are you going to be doing?
Duncan.
Museums. Yes.
I think there's nuts in this. My throat's closing up.
You phone for an ambulance.
I can't breathe properly.
Where's your injector? Your auto-injector?
In my bag.
Tell him it's anaphylaxis.
Hello? Hello, yes, can I have an ambulance, please? Yes, it's my friend. She's having an allergic reaction. Yeah. Yes, it's anaphylaxis. Yeah, we're at the Oak Tree restaurant. Yeah. That's right, Oak Tree. Yeah, on 45 Glover Street. That's right.
Okay.
Yeah.
On 999 immediately. There's no messing around, guys. Once somebody starts to have a bad reaction, you call 999. If they don't end up in hospital, so what? Okay, that's not the worst outcome from the point of view. The ambulance service will bring a ton of equipment and medication that we might need. So prevention here, we're back to prevention. So call 999 112, and they're going to direct you anyway. They're going to get medical direction. And from a first aid perspective, anything that me and you are advised to do by the emergency call takers is referred to in this game as medical direction, which means you're legally covered to implement it. You may be doing something. You may already have a first aid course done, and your first aid course didn't include the following advice from ambulance control. You're legally covered to do it, and the conversation is recorded should anybody have a problem with you. Now, the video, when you watched it there, obviously something in the food. The one part of the video that's totally untrue is that he found that auto-injector very, very quickly in her handbag. All you ladies know you can't find anything in your bloody handbag. If you tilted it upside down, it would be more believable. Well, what I didn't see him do was go back to the handbag and look for all this other medication. Because it's not unusual for them to carry a second auto-injector, because it is quite possible that following an administration of one of those auto-injectors, symptoms can return after about 5 to 10 minutes, and you need your second shot of epinephrine or adrenaline. It's also not unusual for people who have allergies to carry Ventolin. Now you're thinking, oh, hang on a minute, have they got asthma as well? They don't necessarily have to have asthma to carry that Ventolin. Remember what it is, it's a bronchodilator. So where we have a severe allergic reaction, somebody's bronchial tubes are constricting, to be able to take their epinephrine, which will open their airway, but also use their inhaler to keep the airway open. And you can see we've also got an antihistamine there. So if they have them on their person, we would advise them to take these as well. So there's a lot of follow through on medication. The ambulance service will carry bucket loads of adrenaline should you need more of it. And some people do need, and they do need it a lot more. So that's why we would say call the ambulance. So you're covering all these possible angles anyway. For you guys, if any from the school perspective, from talking to teachers here, is that the best advice we give you from a first aid perspective is go back what I said to you, get your care plan in place, sit down with the parents, dot the I's, cross the T's, make sure everything, get all those ducks in a row, get everything in place that you know exactly everything about little Tommy Murphy, or little Mary, or maybe a couple of kids in school. So you have to do everything for each child. So it's care plans, consent forms, information, medication for every individual child. And you're only allowed to administer the medication to Tommy Murphy and his medication. You can't borrow his to help Mary type of thing. So make sure all those plans are in place. And what's interesting, I've been in schools where one child, we open a little Tupperware box that they have, and someone very organized, photographs, important information. And then what they do is you open the box and I see 2 auto-injectors, Ventolin and Zyrtex in it. And then the other one is 2 auto-injectors, and that's it. And I'm always asked, why are they different? So, well, that's down to the GP The GP decides what the child needs, and the care plan will then tell us what it is we can do for that child. If you can go back to that slide for a moment, because there's something an awful lot of people forget to do. If it's possible, if it's happened at home, you've got access to it, and someone's just taken their auto-injector, if you can get them to brush their teeth, especially if it's a food product. We were talking about peanuts there earlier on, so there can be a lot of residue still in their mouth, and that can initiate another, I suppose, attack. So if they can brush their teeth, brilliant, or at the very least, if you can get them in them to wash out their mouth, then you could be potentially removing the trigger, whatever's causing it. And not having to do it immediately. Obviously, treat your patient first, and then look at how can I follow this through. Here's what's going on with adrenaline, because people think adrenaline is removing the allergen. Adrenaline stroke epinephrine, the EpiPen. When it's administered, it reverses what's happening to the individual. The individual's airway is closing, it's tightened, and their blood vessels are opening. When you give adrenaline, it makes your blood vessels constrict, pushes up your blood pressure, and it does this to your airway. It opens it. So it allows people to breathe and allows their body to, create a blood pressure. It's often referred to as a freeze, fight, or flight mechanism in the body. If you need to get out of the way of a speeding car, you need a rush of adrenaline. And your body can produce that because your adrenaline glands sit in your kidneys and you get that burst when you need it. However, in this situation, you need an extra booster. As we go on to the next slide here, because it's important then, you see here, it's important to point out that first aiders in Ireland are not allowed to administer any medications to the patient. However, you can assist the patient with the medication. If the patient's gone beyond the ability to administer their own medication, or you are unsure what to do, call 999 or 112 and follow the medical direction given by the emergency call taker. Now, you may have a situation where you're allowed, you've dotted all the I's and crossed all the T's, and the parents have said if their child has an allergic reaction, that you can administer the medication. Then that's good if you have that in place. And that gives you that safeguard. But we generally, our rule of thumb is that the person has to be conscious and able, and then we assist them. So we go over and we do whatever is necessary. If your patient is confused, disorientated, and they don't know who they are or where they are, 999. Okay, and we're not going near medication unless we're advised to do so. Anybody found unconscious, the general rule is you put nothing into the mouth of an unconscious patient, and you certainly don't inject an unconscious patient. I've had plenty of situations where I've found people unconscious, breathing, and when I do my full exam, I would often find medication on their person, and many an occasion it turns out it's not their medication. They've picked it up in the pharmacy for another family member. So you've probably been told in the past that when you assume, you can make an ass out of you or me. So don't assume at that point. Go back and make sure that the person's breathing, that you have signs of life, and you're on the phone. You should be on the phone anyway if someone's unconscious, and tell them everything. Tell them what you see, what you hear. They will advise you what to do. So you don't have to be on your own. And if you don't have a mobile phone nowadays, then I don't know, you're just landed from the planet Zonk or something, because I think everybody has a mobile phone. And even if you're your own one, if you left it behind you, you're probably guaranteed somebody beside you has a mobile phone. You can use anybody's mobile phone to ring 999 or 112. You don't need to know their passwords or anything like that at all. You can punch that number in. The next slide coming up is basically just what we call the signposting. It's showing you where all this information that I've given you today has come from. So you can get on those websites and they've got an abundance of information, tons and tons of information. So we're on our last slide then. So we want to click it on there. So it's basically just thank you all for attending. I hope it was of some value to you. And now we have a chance that if you have any questions, I don't know if any questions popped up there, Fiona, we can have a look and see.
No questions come in during it, but I'm sure that we'll get some afterwards now. This is also recorded, so it will be up on TY Hub for people to watch back over, share with teachers and staff members, and get the word around. Thank you so much for doing this with us today and getting awareness out there about what asthma is, how to deal with it, how it can happen, and how to react to allergic reactions as well. Thanks so much, PJ, for that. I've definitely taken a few things away from that. I mean, you also don't need credit to ring 112 or 99.
Or a signal, or even a signal.
Yeah.
You get a priority of whatever mast is in the area. So if you have no signal, no credit, you can use anybody's phone to ring 999 or 112.
Fantastic. And if you haven't done first aid, it's definitely a good one to do. Where I know we've been trained anyway, but you also have you just mentioned, like, you do schools, even offices. But even if you have an allergic reaction when you're finished school and you're an adult and you're in a working environment, it's really important to let those around you know that you have that as well. So to have a care plan in place for your workplace as well, I suppose.
You can follow it all the way through. I know a lot of people are very private about their medical conditions and don't always want to advertise them. But you're right. If even if the first aiders in your workplace have an idea what your underlying problem might be, it gives them a slight advantage over should you have any sort of medical emergency, not just an asthma, but anything in general. First aid is a very personal course. Anybody that does first aid training, they need to think it that way. Don't think about, oh, I'm doing it for school or I'm doing it for work or whatever. It's one of the few courses you'll ever put in your back pocket, because most people I've trained over the years ended up using their skills at home on family members, or their buddies out of the football match type of thing. So it's a very personal thing to take on board, and it's not difficult, not that difficult to do. Well, I don't.
It's important to save other people's lives, and having the skill to do so is a life skill, and you can use it if you want to.
Yeah. And I think one thing that people always worry about is legal implications from first aid. We have a Good Samaritan amendment to our civil laws, which protects first aiders perfectly. So you really, as long as you're not doing any crazy stuff, no open heart surgery, no drilling holes in people, you'll be safe. Okay.
What you see on the TV shows is not what you can do in real life.
None of that carry on. That's why we would advise you to do the course, because the course at least puts you on the right track and you know what it is you can or cannot do. And I think from a first aider's perspective, having full knowledge of your limitations and accepting that this is all I can do, which is really limited. But often the most important thing you'll do is pick up the phone and call 999 and 112. And I'm going to give you something from my old ambulance days, if people could remember to do this. If it's a family member and they're on their own, advise them, if they become unwell, to go into the hall, open the hall door, stay in the hall, even sit on the stairs or even on the floor and call for help. Because sometimes the most difficult job we used to have was actually just gaining access to people.
The door.
So that would make a huge difference. So talk to family, especially if you've got elderly family or people with medical conditions, if they can do that, to do so. It'll make all the difference of how quickly we can actually get to you and so on. So thanks, Fiona.
Thanks a lot, PJ. And stay safe, everyone, especially on World Asthma Day. We've let a little bit more know about asthma, and they have all the websites there. We will put them up in the description as well, where you can get information. Very important, go to GP. That's where your starting point is to get diagnosed as well. And every breath matters, so keep safe, everyone. Thanks so much for joining us, and we will see you all again for another TY Hub Live. I think, what, you need another saying this.
Just last thing from me, take your preventative medicine every day. Get in the habit, and then you reduce the possibility of having an asthma attack.
Or anything. If you have to take regular medication, there's a reason why you have to take regular medication. So keep taking it.
But even if you feel well,
even if you feel well. Okay. Anything else?
That's it.
You could keep talking all day, and that is what your job is anyway. So thanks so much for helping us out today on World Asthma Day. And like I said, it's going to be up on TY Hub and YouTube to watch back on, and we will have all the important links in the descriptions. Pop over to FirstAidCoaching.ie to find out more about first aid and get a life skill and save somebody's life. Thanks so much for joining us. We'll see you again in a couple of weeks for our very last, actually, Let's Talk podcast. It's what what's the big idea? And we will be joined by fantastic Kim Mackenzie Doyle about her big idea. And that'll be our last one. That's on the 16th of May. And in the meantime as well, actually, Annie TYs, congratulations for succeeding on a successful 23-24 TY. And I know all the celebrations are happening as well in the next couple of weeks. So stay safe and we'll see you all again soon. Bye.